For decades, senescent cells have been framed as aging slow saboteurs, creeping in with time, cluttering tissues with their inflammatory secretions, and interfering with regeneration. But when it comes to skin cancer, particularly melanoma, the narrative gets a lot more sinister. These zombie cells don't just clog up tissue and fuel wrinkles. In the right, or rather, wrong context, they may actually prime the skin for malignancy. And it's not just the presence of senescent cells that matters. It's their subtypes, their behavior, and their relationship with UV exposure and the immune system. In other words, some zombie cells may simply loiter, while others quietly roll out the red carpet for cancer. It all starts with ultraviolet radiation, the grand villain of skin biology. When UV rays strike the skin, they cause DNA mutations, oxidative stress, and inflammation. In response, many cells, including melanocytes, keratinocytes, and dermal fibroblasts, undergo a protective form of stress-induced senescence. This cellular lockdown is meant to prevent replication of damaged DNA, acting as a tumor-suppressive mechanism. That part is good, in theory. But here's the twist. These senescent cells, especially if they persist for too long or occur in high-risk tissue zones, may shift from protectors to enablers. Their senescence-associated secretory phenotype, SESB, which includes inflammatory cytokines, IL-6, IL-8, growth factors, VEGF, HGF, and matrix metalloproteinases, creates a microenvironment that fosters mutation accumulation, immune suppression, and tumor invasion. And that's where melanoma risk gets tangled with the senescence map. Recent research using single-cell sequencing and spatial transcriptomics has started to reveal that senescent cells in the skin are not a monolithic force. Rather, they comprise distinct subtypes, each with unique signatures and spatial distributions, and not all are equally risky. One particularly ominous group are SESB-high fibroblasts that develop after chronic UV exposure. These cells produce high levels of pro-inflammatory and pro-angiogenic signals, essentially creating a mutagenic niche just beneath the epidermis. Studies have shown that melanocytes in proximity to these cells show higher rates of DNA damage, increased expression of survival signals, and decreased apoptosis, even in the presence of UV-induced lesions. This suggests a possible indirect oncogenic pressure, where senescent fibroblasts push damaged melanocytes to survive and persist when they should not. Then there are immunosuppressive senescent cells, often found in aged or photo-damaged skin. These cells express markers like PD, L1, and secrete TGFSS, which can inhibit local T-cell activity and blunt antigen presentation. In essence, they create a local immune-privileged zone, a soft spot where early-stage melanoma cells may escape detection. This aligns with clinical observations that older individuals, whose skin is more heavily populated with long-lived senescent cells, tend to have higher melanoma incidence and worse outcomes. Interestingly, melanocytes themselves can become senescent, especially after acute sunburns or oxidative stress. While this senescence may initially act as a protective halt, senescent melanocytes can also contribute to immune dysregulation and pigmentary changes. Some researchers now believe that a subset of senescent melanocytes could become melanoma precursors, particularly if they harbor mutations in BRAF or NRAS and evade immune clearance. These protomelanoma cells sit in a molecular limbo, damaged, non-dividing, but poised to escape if given the right trigger, such as additional mutations or a permissive microenvironment. So how do we use this knowledge to predict or prevent melanoma? First, by identifying and mapping high-risk senescent subtypes in UV-exposed skin. Technologies like senescence-focused spatial transcriptomics or skin RNA patch testing could help clinicians detect early clusters of SASB-heavy fibroblasts or immunosuppressive senescent melanocytes. A future skin check might involve not just scanning for moles, but assessing your skin's senescence burden and whether it's tipping toward a pro-tumor profile. Second, there's a growing interest in senescence-targeted chemoprevention. Senolytics, drugs that selectively eliminate senescent cells, could one day be used not just for cosmetic anti-aging but as a protective measure in high-risk populations, such as fair-skinned individuals with a history of sunburns. A topical senolytic cream, applied seasonally, might clear out SASB-heavy cells from sun-damaged skin before they create a cancer-friendly niche. Third, immune senescence interplay is now a therapeutic frontier. If certain senescent cells suppress immune surveillance in the skin, They might be targeted with immune checkpoint inhibitors or xenomorphic agents that reduce their suppressive secretions. In theory, this could reawaken the immune system's ability to eliminate precancerous cells, improving melanoma prevention, especially in older adults. All of this suggests a fascinating, if slightly unnerving reality. Not all zombie cells are merely bystanders in aging. They may be the conspirators behind skin cancer's rise. And while senescence is a natural safety mechanism, in some cases, it's like a fire alarm that never turns off, triggering more chaos than it prevents. The future of melanoma prevention may lie not just in sunscreen and mole mapping, but in cellular landscaping, clearing the senescent clutter before it becomes dangerous, distinguishing between protective senescence and permissive pathology, and using biomarkers to monitor skin's precancerous moods long before malignancy begins. Because in the long war between the sun and our skin, the zombie cells may not be on our side for long.